Can start the session, sir.
Okay. Good afternoon, everybody. Welcome to this webinar on Carbetocin in action, case studies from labor room by Heathrow. Doctors, as you know, Heathrow Healthcare is a company with 25 years of excellence, 36 state-of-art manufacturing facilities. We have 300 plus products in our portfolio and 120 presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. Heathrow Healthcare has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is a 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide range of products encompassing multiple specialties like gynecology, dermatology, orthopedics, etc., pulmonology, etc., pioneering in quality and innovation. And Heathrow Healthcare has the distinction of bringing to 4 biosimilar products to market within 5 years of initiation. With this brief introduction of Heathrow, I will welcome you once again. And Carbetocin, my dear, as you all, my dear friends, as you all will agree with me, is a drug which is used for prophylaxis of PPH. And PPH is a condition which can lead to disaster. Although there are many papers published on PPH and role of Carbetocin in prophylaxis, we always like to have experience of our own doctors, insights of our own doctors, which are very valuable to us in management of PPH by Carbetocin. For which today we have got Dr. Aanandita Swami Banerjee. Welcome, madam, to this webinar. Dr. Banerjee is MBBS MS Obstetric Gynecologist, consultant at Banerjee Clinic, Yathartha Hospital and Cloudney Hospital, Faridabad. With this brief introduction, I hand over the session to madam for her views on PPH and Carbetocin. Over to you, madam.
Good afternoon, sir. Happy New Year in advance.
Yes, Happy New Year to you, madam.
So, postpartum hemorrhage has always been the most dreaded complication for any obstetrician or gynecologist. PPH, daunting event. PPH is loss of at least 500 ml of blood flow, as we know, in a vaginal delivery and about 1 liter after a cesarean section. PPH is common and can occur in women who are not even at risk. PPH is the leading cause of maternal mortality in low-income countries and primary cause for nearly 1/4 of the maternal deaths globally. Maternal mortality is the leading cause of maternal mortality, accounting for about 35%. MMR in developing countries was 240 per 1 lakh live births compared to 16 in developed countries. Global PPH incidences of 14 million women suffer from PPH. Incidence of PPH is reported to be 2 to 4% after a vaginal delivery and more after a cesarean, which is 6%. PPH incidence in India is 38% of maternal deaths are due to PPH. 25.7% of global deaths take place in India, and 2/3 of these attribute to PPH. India has an unexpectedly high maternal death rate of 540 per 1 lakh live births. As we all know, what can be the causes of PPH? The most common is the tone, the thrombin, trauma, and tissues, the 4 T's. Tone is the uterine atony, inability of the uterus to contract, which may lead to continuous bleeding. Thrombin, the coagulopathies, failure and clotting. Trauma, uterine trauma, injury to the birth canal, rupture, uterine inversion or lacerations. And tissue when there are retained placental bits or abnormal placenta. How do we see whether the patient has a PPH or not? When she has abdominal tenderness, circulatory collapse, increasing abdominal girth, loss of uterine contraction, maternal tachycardia, vaginal bleeding. How do we classify PPH? We should be very cautious about the PPH. It can be a compensatory phase, mild, moderate, or a severe phase, wherein the blood loss in compensation is 500 to 1 liters, mild is 1 liter to 1500 ml, 1500 to 2000 in moderate, and in severe it is more than 2 liters. The blood pressure is maintained in a compensatory phase. There's a slight fall in mild, markedly fall in moderate, and a severe fall which is MAP of 50 to 70 in severe PPH. Symptoms and signs, again, the palpitation, dizziness, and tachycardia in a compensatory phase. Mild shows weakness, sweating, and tachycardia. Moderate has restlessness, pallor, and oliguria, while a severe shows a collapse, air hunger, and anuria. How do we diagnose BPH? We initially evaluate the patient for rapid assessment of the patient's status, presence of tachycardia and hypertension, assessment of vital signs and blood loss, examination at the time of hemorrhage, assessment of the entire genital tract for any laceration, hematomas, or sign of uterine rupture, manual examination for retained placental tissue, assessment with the bedside ultrasound to check if there is any, if the uterus is non-contracted or if there are any placental tissues. Evaluation of the uterus to check for the uterine inversion should be done. If possible, we should always send for the laboratory assessment for the CBC, hematocrit, and the platelet. Coagulation studies and assessment of fibrinogen should also be done. How do we approach towards it? We have to first classify ourselves that whether the PPH is because of the poor uterine tone, the tears or trauma, or it is because of the retained tissue, or it is because of the coagulopathy. Clinical findings where there is a poor uterine tone is uterus feels relaxed, boggy and soft. The uterine fundus may be felt well above the umbilicus if the uterine cavity is filled with blood clots. Investigation: the full blood count, coagulation profile, urea and electrolytes. If patient is not responsive to fluid and blood replacement, abdominal ultrasound to rule out uterine rupture or intraperitoneal bleed. How to manage? Uterotonic agents are used, which are oxytocin, prostaglandins, and ergot alkaloids. Hemostasis algorithm, C. Maynard. Uterine balloon tamponade. Then there are tears and trauma, where the bleeding, the point of bleeding should be, we should localize it, whether it is because of the uterine rupture or extension of the uterine angle. Tears due to cesarean during the cesarean section. Extragenital causes like a subcapsular live rupture or rupture of the ovarian splenic vessels. Investigation sent again the same. Inspection should be done during the cesarean section, and ultrasound might help to localize those tears and trauma. Then there is retained tissue, retained placenta and membrane. We should identify with the bimanual examination. Examination should be done under anesthesia, and the retained placental tissue should be removed. And for the coagulopathy, we have to arrange for the clotting factors. So what is the rationale for development of carbetocin in a new which is a new heat stable formulation? Oxytocin and ergot alkaloids should be kept in the refrigerator. While heat stable formulation of oxytocin is not available in India right now. Previous formulations of carbetocin were obviously they should have been stored at 2 to 8 degrees centigrade. Resource poor countries do not always have a cold chain transport and storage capabilities. Carbetocin is stable at room temperature. Its half shelf life of 24 months at 30 degrees and 75% humidity. It avoids the need for cold chain storage and logistics and is provided in a vial. Use of uterotonic agent. Time of administration. It can be given at the time of at the crowning of the baby's head, at the delivery of the anterior shoulder, at the end of second stage of labor, following the delivery of placenta. Prophylactic use, prevention of PPH, active management of third stage of labor, therapeutic use, management of PPH, where oxytocin, carbetocin, ergometrin, symptometrin, misoprostol are used. Carbetocin, a next generation drug for PPH management. The drug is a synthetic long-acting analog of oxytocin. Therapeutic indication, prevention of PPH due to uterine atony. Posology and administration. One vial contains 100 microgram of carbetocin in 1 ml solution for the injection. This prolongs the half-life, reduces the enzymatic degradation. Clinical evidence. Okay, this was a champion trial which was done and which proved that the carbetocin is non-inferior to oxytocin. The study design, non-inferiority, double-blind, randomized trial, objective to compare the effectiveness and safety of investigational heat-stable carbetocin to oxytocin in the prevention of PPH after vaginal births. Patients enrolled were 30,000 women across 10 countries. Primary outcomes: the proportion of women with blood loss of at least 500 ml or the use of additional uterotonics, the proportion of women with blood loss of at least 1 liter. Carbetocin, parameters, where carbetocin and oxytocin, the blood loss of more than 500 ml or use of additional utrotronic in carbetocin group was 14.5%, while in oxytocin group was 14.4%. This was when the cold chain of oxytocin was maintained properly. Blood loss of more than 1 lakh was seen in 1.51% females, while with oxytocin was 1.45%. At least one unanticipated acute event, safety profile wise, 4.9% in carbetocin and 4.7% with the oxytocin. The frequency of blood loss of at least 500 ml or the use of additional utrotonic agents with carbetocin was proven to be non-inferior to oxytocin. The use of additional utrotonic agents, interventions to stop bleeding, and adverse effects did not differ significantly between the two groups. It was concluded by the champion trial that carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional utrotonic agents. Again, this was a Cochrane review where carbetocin for preventing the PPH was studied. In the Cochrane review, data from 11 studies involving 2,635 women were included. The author concluded that for women who undergo cesarean section, carbetocin resulted in statistically significant reduction in the need of therapeutic utrotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer adverse effects. Guideline recommendations. Okay, so it has been recommended by WHO as one of as first line drugs for the prevention of PPH or AMTSL. SOGC Canada also recommends carbetocin. Ranscog New Zealand active management using the prophylactic uterotonics. Figo says carbetocin is recommended. Germany also now recommends the carbetocin, while FCOG France also carbetocin on proving non-inferiority to oxytocin achieved by the champion trial. This is my experience with carbetocin. Okay. We are beginning with the case G2P1L1 with 30. This was a case where it was second gravida with 38 weeks with previous cesarean anteriorly placed placenta, which was placenta previa. Patient came with complaints of pain in abdomen at 9 months amenorrhea with mild anemia and was planned for LSCS after cross-patching 2 units of blood. LSCS was done, and after delivering the baby, immediately injection carbetocin was given IV bolus and placenta removed in piecemeal due to non-separation of placenta. Bleeding from the small oozers stopped by compression and uterus was closed in 2 layers. Post-operatively, patient was uneventful. This was another case where G2P1L1 with 40 plus 3 weeks came with a big baby, which was around 3.5 kg, with complaints of labor pain since 2 days on and off. Patient came at a dilation of 3 centimeters with mild contractions and ARM was done. Labor progressed well spontaneously and patient delivered a baby of 4.5 kg. Patient was given injection carbetocin IV bolus in view of suspicion of PPH and patient did well. The third is a case in vaginal delivery. Gravida 4 para 1 live 1 abortion 2 where patient has taken MTP kit twice with 38 plus 3 weeks with labor pain since morning on and off. Patient came in active stage of labor at 3 centimeter dilation. ARM was done. Labor progressed precipitously. Within an hour of ARM, patient delivered. AMTSL was done. Patient was kept in LR for 1 hour for observation. Within 20 minutes, patient started bleeding vaginally. Cervix vagina was explored, which were NAD. Uterus was relaxing intermittently. Bolus injection carbetocin was given. Bimanual massage done. SR Foley's catheterization done. The uterus still felt relaxing intermittently, but it was delayed now. So, a second line drug was given, which was injection carbetocin, which was given IM, and finally the tone of the uterus was achieved. How is my experience on?
Oh, that's what I said. Interesting cases you have seen, especially the third case I was interested. Despite using oxytocin, carbetocin, the patient still was bleeding, and
Yes, sir.
you had to use carboprost in that case.
Huh, sir. But then
Yes,
it was a synergistic effect of
yes, correct,
carbetocin and
correct.
carboprost was really nice.
And that too, when you see the case, apparently it appeared to be a normal case. We didn't expect a disaster there when
PPH.
she
Yes,
started
sir.
bleeding. Yes, that's the whole thing about PPH. It happens exactly when we don't expect. That's the best thing. And I see for this simple patient, you have to manage three drugs. Although three of them work synergistic actions, one thing, but you cannot expect. You cannot expect carbetocin to work in all the patients. Yes,
Yes, sir.
yes,
Sir, but one thing is because the cold chain of oxytocin is not maintained,
correct,
we are
correct,
left
correct.
with carbetocin as the main
Absolutely,
recipe.
absolutely. And madam, in this, you have been using carbetocin since how long?
Sir, I have been using it since 1 year.
1 year.
And
And most of the time you have used IV or IM?
sir, IV only.
IV only. And a
Huh.
bolus injection, as you have seen in the three cases. And even with this bolus injection, there was no change in cardiovascular parameter or any
Sir,
such thing.
there is tachycardia initially
Tachycardia, yes, yes.
for around 30 seconds or something.
Okay, okay,
But then
okay.
it settles down.
It settles. A short, but nothing major.
Major.
Nothing, yeah, yeah.
Like how what happens with carboprost is patient suddenly starts
Oh,
vomiting.
yeah, yeah, yeah.
With methergin, patient also vomits again.
And
But
blood pressure
carbetocin,
shoots. Yes,
and the blood pressure shoots.
shoot.
But the
And
carbetocin is a very comfortable drug to give.
I mean, the symptoms of vomiting, loose motions, I think their golden moment is something not wanted. Yes,
Yes, sir. So my experience has overall been very good,
very good.
especially for the placenta previa. It worked
Ah, yeah,
wonders.
yeah. The first case that is for the placenta previa placenta
It
previa.
worked
But
wonders,
in
sir.
general, madam, how common is placenta previa?
Sir, it is not very common. Like
Ah,
the incidence must be around 5 to 6%.
and how common is BPH with placenta previa, or you would not take any risk?
I have not taken a risk,
Yeah,
sir.
yeah, correct, correct.
PPH is pretty common with twins. PPH is common with placenta previa, but nobody
Previa.
wants to take a risk.
Absolutely, absolutely. And we know the outcome. It could be a disaster. Yeah.
Disastrous. Yes, sir.
Which is what, although you can expect PPH, anticipate PPH
Sir,
in any
PPH
patient.
can be anticipated anytime and in
Yes,
any patient.
yes. That which we saw in
Especially
third
with the
cases.
especially with the scenario, sir, where we are inducing the patients, where the augmentation of labor is
Ha,
given.
ha, ha, ha.
Somehow the patients land up into precipitate labor and things like this. So PPH can happen to anybody.
Any time there is a relaxation of uterine tone, I think the PPH can happen.
Hmm.
Even with magnesium sulfate, if it's used sometimes, it can relax the uterus
Yes, sir.
and
Magnesium
can,
sulfate is a uterine
yeah,
relaxant.
yeah, yeah,
Yes.
it can
There is
predispose
a
the
risk
patient.
of PPH with
Correct, correct, correct,
in severe preeclampsia.
correct, correct, correct.
So, but then I have a question. They
Yes,
say carbetocin is completely contraindicated in eclampsia patients and pre-eclampsia
correct.
patients.
That is because they don't have experience. So you do not
Probably
know,
because.
Yes, we do not know what would be the outcome. So better not use honestly. Honestly, our textbook brand oxytocin has been used for decades and generations. Even I was in college, which is last century. Even at that time, oxytocin was a drug. In my
Huh,
time, madam, we saw patients of PPH, and at that time we had only oxytocin and methergine.
oxytocin. Hmm.
Methergine. And it was, I was in JJ Hospital in Mumbai at that time. And
Yes, sir.
then with one case of PPH, the whole hospital, the whole obstetric gynec unit was there. You know the danger.
Hmm.
I'm talking about the 70s, late 70s.
Yes,
So
sir.
we didn't have anything. Massage, everything was being done, and OT was kept ready in case.
Hmm.
I
That
mean,
is
that is,
how, because
yes.
syntocinon does not have any
And,
vasopressin-like effect, but
exactly.
carbetocin is still
Yes,
unheard of as a
yes,
hence.
yes. When would you actually prefer carbetocin or oxytocin? Okay, in any high risk patient is one thing, but otherwise carbetocin over.
Sir, going by the scenario right now, I
Uh,
prefer carbetocin to be given to every patient because
absolutely.
here the cold chain of oxytocin is not
Correct,
maintained at
correct,
all.
correct. And especially in peripheries, if you go to see, now the cold chain is difficult. Even in places like Mumbai, there's a lot of power outage. So you don't know what will
Hmm.
happen to the cold chain. In interior periphery, it will be still worse.
It is like
And
this only.
yes,
So why not carbetocin?
exactly, correct. Do you have any experience, madam, of using of carbetocin in retained placenta?
Sir, it was not exactly a retained placenta, but yes, the placental beds were retained.
Okay.
So we gave her carbetocin and did a bimanual exam.
Okay. So along with bimanual evaluation,
yes, sir. So it worked wonders.
Both it was uneventful. This is a very interesting question coming from across India. Can we use carbetocin in RH negative mothers?
Sir, yes, it can be given,
It can be,
but there's no contraindication to not to give carbetocin.
Correct. And RH negative mothers getting PPH could be a disaster, especially again in
Disastrous.
periphery, because you should get blood, etc. I mean, it's not a simple thing. Can a doctor use carbetocin for prevention of PPH if oxytocin is used for labor induction?
Yes, any day.
Can. Generally,
because the
oxytocin is
effect
used
of
for labor.
short-lived, 8
Yes.
minutes around. So yes, we can.
We can use. I mean, everyone would be using oxytocin. We have seen in these are textbooks of gynecology.
Yes, sir.
For augmentation, I suppose in most of the patient, oxytocin is used, I suppose.
Yes. For augmentation, oxytocin is used. Some of the people are using misoprostol, but then again, the chances of PPH are more.
Yeah. In which cases you would prefer IV? Now you are
Sir, I
using
usually prefer IV.
IV. But what would be the place of IM in your opinion?
Sir, IM takes a little more time to act. So who has time when we suspect
PPH you will never have time. I mean, microseconds would matter. I was just wondering, what do you think is how do you think place a pre-filled syringe direct IV route? Would it make any difference?
Sir, here we are not, when we ask the staff to give an IV bolus, so they inject very fast. So what we do is, we put it in a 100 ml saline bottle and give it slowly over a minute.
Okay.
So that is how we give an IV bolus. A pre-filled syringe is not a bad idea. If it is a 50 ml syringe probably. Correct. Which goes a little slow.
Because the speed is also important. Other patient can get other complications. If the patient is not responding adequately, which you saw in case number 3 with carbetocin, you have used carboprost as one of the additional drugs. Yes. Your preference is carboprost.
Yes, sir, because carboprost has lesser of cardiac event.
Only thing is that asthma safety. I mean,
we should just rule out the asthma part. Rest of carboprost is better.
What are advantages of carbetocin over oxytocin? Madam, specifically over oxytocin, how commonly you have seen those ADH-related side effects?
Sir, very rarely. Because whenever oxytocin is given in an infusion, anybody here and even me would prefer to give carbetocin rather than giving oxytocin infusion.
Correct. And advantage of misoprostol?
Over misoprostol, fever and chills are not there with carbetocin. Patient usually develops
immediately they get and more than patient, the relatives will get more panicky. That's the situation. Yes. Carboprost we have seen. Yes. And methyl ergometrin, apart from hypertension, any other side effect?
Vomitings.
Acha, with methyl ergometrin.
Yes, sir, methergin also causes vomitings, nausea.
And methyl ergometrin, I think, contracts both the upper and the lower segment, unlike carbetocin, which will only contract the upper segment, I suppose.
Yes, sir.
Should carbetocin be, I mean, this is a redundant question. You have been using it as a first line.
Sir, it should rather be used as a first line because we know that oxytocin, the cold chain is not maintained.
Absolutely. How would you compare now? This is only adverse effect profile of carbetocin and vis-a-vis oxytocin.
Sir, in my eyes, as far as my experience goes, I have never ever any side effects I have contracted for carbetocin besides that tachycardia.
Yes.
That's
and oxytocin any side effects you have seen?
No, sir, just that it doesn't act.
Yeah, that's the main biggest issue. Okay, madam.
With the carboprost, we have seen all those vomitings and things like that.
Yes. And how common is this thing with misoprostol side effect?
So misoprostol is just that patient develops fevers and chills. That's it, not much. But it takes time to act. Even if you put it per rectally, it takes a little time to act. So
probably carboprost acts faster than misoprostol.
Because
of route of administration.
And during the cesarean section, carboprost can be given directly into the intramyocardium also. So it is a little faster.
So just to conclude, your one-liner on Carbetocin for the audience. Message, take home
Now is
message.
the time. Now is the time I feel that carbetocin should replace oxytocin, where we were using oxytocin as the first line drug for PPH. Now I feel carbetocin should be used, especially in tropical countries like India, where cold chain is a problem and also the weather is a problem.
Correct.
So carbetocin will score over oxytocin in my eyes.
Right, madam. Thank you so much.
Thank you so much, sir.
In fact, this is exactly what we want our audience to know. What's the place for Carbetocin? So there are plenty of papers showing it is effective, sir. But our own doctors telling their experience is what we actually want. Thank you very much for all this. Thanks for your
Thank
case
you so
studies.
much,
Thank
sir.
you. It was a
Oh,
lovely session. Thank you.
thank,
And once again, wish you Happy New Year.
thank you, sir. Same to
God
you.
bless. Thank
Okay.
you. We can sign off.
Yes.
Shashidhara, thank you very much.
Okay, sir. Thanks for your time.
Yeah, we'll again meet at 4:30.
Sure, sir. Definitely.
Yeah.
4.
Okay. 4:30, the session I was told.
4, sir.
4.
4 or 4:30? Priyanka?
Just a
4.
moment. Let me check, sir.
Shashidhar, doctor said 4:30 now. Okay, so
Okay, ma'am.
start at
Okay.
4:30, we'll wind up by 5:15.
Sure, definitely.
Yeah.
Thank you.
Thank you.
Hello.
हाँ बोला मैडम.
एक मिनट. Shashidhar,
Hello. Ma'am, you are in mood?